Okay, fantastic. So if everyone has come back, we'll get started so we can try to stay on time as much as possible. It's my great honor to introduce Dr. Haik Kavukjian, who's going to teach us all about hand infections. Haik, please take it away.
Yeah, thank you, Nadir. Uh, no financial disclosures. I do feel compelled to mention that I was not asked to talk about hand infections because I get a lot of infections on the patients I operate on. Rather, following Dan and break, the committee wanted to keep the momentum going with a good talk. So we do have a big topic. We're going to jump right in. I think one of the things about in medicine in general, if you can develop protocols for the way you approach problems, it'll allow for thoroughness, make it more interesting, avoid missing critical issues. And with that, although we have protocols, it's good to be flexible. With infections or anything relating to medicine, we start with the history. We were always taught that, and the history gives us so much information, probably up to 90% of all we know. So as I approach patients with hand infections, I want to know about the mechanism of injury, the time of the injury. Most are direct inoculation, progression of development, prior related treatments, including antibiotics they may have been on, any history suggestive of a more systemic problem such as fever, chills, progression with throbbing, swelling, sensory changes, other medical conditions. Certainly the immune status of the patient. Are they on immune suppressive agents such as Enbrel, Humira, history of diabetes, organ transplantation, AIDS and HIV, tetanus immunization. Remember, as you're approaching these patients, anything that you drain or swab, you want to do a gram stain on, you want to get cultured, even if there's no visible purulence. If in a perfect world, if whatever you culture, if you also send a specimen to the pathologist, that will add to the information that you get. Splinting and early therapy are critical. Elevation is critical. When you first get a call to the emergency department, before you even see the patient, make sure they're NPO. So often we go down to the emergency department, patients have hands and coke there, they just had that. You needed to go to the operating room, and that really disrupts things. Once you've seen them, just make them NPO if they're being admitted, and you can reassess that status. Remember, if the discussion comes up, should they or should they not be hospitalized, I would always err on hospitalizing, especially that unreliable. Although I wouldn't say I love treating hand infections, I do find it positive in that there's a challenge there that you can also benefit the patient with. And one of the reasons for that is anatomy is critical. Hand infections often progress in a very predictable pattern. The reason for that, the hand is made up of spaces, the joints, the tendon spaces, the potential spaces, such as the thenar space, as well as the mid-palmar space and corona space, as well as the hypothenar compartment and the thenar compartment. The issue here is infections can go from one compartment to the next. That often will give you ease in terms of how to treat them. Remember, history, going back to history, can predict the bacteriology. Human bites, or what we call fight bites, are often infected with staph, strep. The most characteristic bacteria is Legionella coronas. Similarly, cat and dog bites are often polymicrobial. Pasteurella is the most characteristic. If you're seeing a dental or healthcare worker, you want to think about a herpes whitlow. And if you're seeing someone with a fishing injury, if it's a food infection, Vibrio species should be top on your list. If it's more of a chronic indolent infection, Mycobacterium marinum, especially if it's not responding. Going along with further general treatment strategies, MRSA. Classically, we talk about methicillin-resistant staph as being associated with patients with intravenous drug use, close to living quarters, such as jails, even shared athletic equipment, things that seem benign, prior antibiotic use, age, and immune suppression. There was an alarming study that came out back in 2007. In that study, 60 to 75% of community hand infections were MRSA. It's now gotten to be probably the norm. What is of interest is that community-acquired MRSA is more virulent than the hospital nosocomial acquired MRSA. So as you see these patients, you're going to want to say, are they from an urban setting, a severe infection? If so, you're going to want to start them on intravenous vancomycin, or clindamycin is a good alternative. until you get some type of culture back. Alternatives would be linezolid, intravenous trimethoprim sulfate, cycline, daptomycin. These are all medicines you will probably need infectious disease. Less comorbidities, you can take a chance, start them on Bactrim, clindamycin, doxycycline. I've come to rely very heavily on infectious disease consultation. They add a lot of value there. They provide a collaborative approach, and I think it generally improves patient care. As we start the workup of patients with infections, imaging is critical, although people downplay the value of plain imaging. Excuse me. Plain imaging should always be a first must on all these patients. You're going to want to see, is there air in the soft tissue? Remember, although air in soft tissue can be a very ominous sign with the gaps producing bacteria, these patients generally have open wounds, so it's not unusual just because of the open wound to have air in the soft tissue. There could be foreign body debris, prompting the need for more thorough irrigation. Could be a broken tooth, such as what you see here, as well as the bone injury. Plain imaging is also good for helping establish acute or chronic osteomyelitis. That will often appear as early as 10 to 14 days, sometimes sooner, where you'll see bone changes. But also it can give you a sense, is there something else going on? Is there an acute gouty attack? And in that setting, plain imaging may be negative, but with the more chronic, you'll see characteristic periarticular erosions. An element of pseudogout, which you'll see, we'll touch on that a bit later, is ulnar site calcification in the ribs. MRI used to be the exception. Now it's gotten to be our go-to testing. Classically, we'd like to use this in patients failing to respond. MRI provides excellent sensitivity for occult collections, excellent sensitivity for osteomyelitis with bone marrow edema, showing you'll see some type of cortical signal abnormality. Worth noting, on MRI, neoplasms as well as malignancy will be indistinguishable on T1 and T2. This is someone with osteomyelitis of the distal phalanx. On a T1 signal, you have low intensity out in the distal cortex. You can see the normal marrow pattern here. When you go to T2, which is a fat suppressed sequence, you can see the entire area enhancing. You can see the marrow going out there. There is still a role for bone scans, although they were in the past felt to be the workhorse for diagnosing infection. There's still some use for magnesium, gallium, and labeled white cells. They offer the advantage of being very sensitive, but they lack specificity. Another disadvantage, they can take up to 24 hours to get the results. Probably the biggest advantage is they're very valuable in terms of locating multiple foci of pathology. So we're going to just jump right into this because, as I say, we have a large area to cover. So cellulitis or lymphangitis, this is a condition where there's no abscess formation, generally no involvement of deep space or tendon space. We treat these initially with IV antibiotics. We're covering skin flora. History will give us, will suggest direct trauma to the area. Since we don't have anything to culture, blood cultures are worthwhile obtaining, as well as nasal swabs, which can guide treatment. Follow-up exams with a Sharpie is a good little technique. Marking the area of erythema, putting your initials in the date, and then just following for progression. Remember, although on initial presentation there may be no abscess, these do coalesce requiring drainage. Perinacial infections. In the acute phase, we treat these, or I'll back up, these are painful nail fold infections. One of the most common that you'll see starts with just induration, tenderness, and some swelling there. Initially, nothing to drain, but over several days, fluctuations develop. Characteristically, oral flora are the culprit. People bite their nails or cuticles, they see. For an abscess, once it is established, it's to be treated with incision and drainage. You can either remove part of the nail plate along here, undermining the nail fold and elevating off the nail plate, or if warranted, you can remove the entire nail. Gram stain and culture is important to guide your treatment. Begin all antibiotics. You can start saline soap the following day. With more chronic perinacial infections, these are patients who are not getting better. There's intermittent erythema, often a history of diabetes or some type of immune compromised status, often chronic water exposure. And on exam, there'll be some separation of the tissue with a superinfection. polymicrobial, they're treated with antibiotics and antifungals. If they're non-responsive, it may require marsupialization, in which we take a full thickness rim of skin over the germinal nail matrix, allowing that to heal secondarily. Felons. These are deep infections of the digital pulp. They're very common, though. They're considered to be a compartment system. The reason that's the case, Dan had shown with the anatomy of the fingertip, you have distal phalanx, you have vertical septae attached to the skin. When bacteria starts to seed in this area here, it's a tight compartment, there's no place to go. The area is lined exquisitely with nerve fibers, which become very uncomfortable as the pressure moves up there. So they're tender, they're painful, they're swollen. They can progress from a perinucleal infection here down into this area here. And they're treated with incision and drainage. The location of the incision is critical. You want to make an incision along the border of the digit. You want to incise down to the phalanx. And then using a snap, you're going to try and break up these vertical septae, which are the chambers that contain the pus. Things to avoid is the fish mouth incision. They become very tender. They become unstable. They take a long time to heal, and they look unsightly. Remember, if you're planning your incisions for the thumb and the small finger, the little finger, you want to make the incision along the radial border of those digits. And the reason you would do that is as the wound heals, you will avoid painful neuromas and nerve contact. For the index, middle, and ring fingers, you're going to want to make the incisions along the outer border. In a perfect world, if you can hold antibiotics pending the culture results that will increase the yield, you'll begin soaking the next day. I'd probably pack this the first 24 hours. Viral infections. These can be difficult to distinguish from a felon or perinucleal infection, often at high elements of occurrence. What will appear very characteristically are small vesicles. Generally, they're out in the tip. There's erythema. There may or may not be a history of the patient being a healthcare worker or a child. Remember, the latency for this can be 2 to 14 days. So it may not appear immediately. Herpes simplex is the most common. As I said, it can also, although more common, distally can be proximal. If your lab is capable of doing a zinc smear, will show giant cells that will be immediately and guided treatment. If not, you may have to rely on viral cultures or PCR that may not be sent out. To be underlined, you do not want to IND these reports of superinfections and encephalitis that occurred. Generally, the untreated viral infection is self-limiting. Valcyclovir, famciclovir can shorten the duration of symptoms. The pyogenic Flexutina synovitis. This is a condition where bacteria gets seeded into the tendon sheath. And if you think back to the anatomy of the finger, you have tendon sheaths which run along the palm through which the tendons lie. Those are closed spaces. Bacteria enters into there, or it can be from a felon, like out of the thumb, that ruptures into that. And then infection will spread from distal of the location of entry proximally, often into the forearm, giving you a rapid progression of infection. There's an entity called horseshoe infection, in which bacteria enters the tendon sheath of the thumb, or the small finger, and progresses down into the palm. In a certain number of patients, the communication between the two bursal sacs and the entire outer rim of the hand will become infected. One of the ways to establish if that's present is tendon to along the palm and the carpal canal, so that should always be checked. With the pyogenic Flexutina synovitis, there are 4 very unique signs called the Knavel signs, often asked of the students or the residents of the scrub sink. These will be flex posture of the finger, and the reason the finger flex is in the pus in the tendon sheath. When the finger is flexed, there's more room to accommodate that, so instinctively the finger drifts into that position. There's symmetric fusiform swelling, where the finger will look like a sausage or a hot dog. There's pain on passive extension, but the most specific is tenderness of the tendon sheath. Remember, these are just suggestive, not specific. Treatment for this, early presentation, meaning less than 12 hours, you're going to want to start with IV antibiotics. You may avoid needing to take them to the operating room. You can attempt to aspirate over the tendon sheath. If there's turbulence there, you'll have something to guide treatment by. If it's greater than 12 hours, invariably these will require operative treatment, extensive irrigation through the tendon sheath, IV antibiotics. There used to be a feeling that you could speed up recovery by continuous drainage postoperatively on the floor with some syringe is fortunately shown not to be effective, fortunately, because it's very cumbersome and difficult to manage from a nursing point of view. Collar button abscess, a little more unusual. These are infections between the distal index along the metacarpal fingers present with abduction. There's abscess formation both volarly and dorsally. And you can see here the abscess volarly as well as dorsally. These require generally 2 incisions to try and avoid a transverse incision. At this point, the audience is probably thinking there's an awful lot of orthopedic hand evil, and there is in the way of infections. But this is an entity which is rare, but we do see it. It's called a mid-palmar thenar space infection. The thenar space over here is radial to the vertical septate of the long finger metacarpal, and it's lower to the adductor muscles, normally not a space that we encounter. The mid-palmar space, another area where the infection can hide out, is along the radial border of the vertical septate the ulnar border of the vertical septate of the long metacarpal, and the radial border of the vertical septate of the small finger, deep to the flexor apparatus. Patients present with this with a history of intravenous drug use. The hand is often swollen in the palm. There's a convex appearance there. They have an elevated fever, white count. They're not getting better. You've been treating them with antibiotics. MRI is essential to help you with diagnosis. It will also guide you in terms of surgery. Treatment will be incision, drainage, culture, IV antibiotics. Clenched fist bite, actually a common entity which is often missed. One of the reasons it's missed is you'll get a call from the emergency department. Seemingly benign wound. Someone hits someone else, mouth open, small break in the skin here. The problem is when the hand is in a clenched fist position, the extensor mechanism is pulled all the way down here. So a laceration.
I'm sorry to interrupt you. We're having a hard time hearing you. I don't know if you have a mic to plug in. If not, that's okay. Carry on. Or maybe just speak.
Okay.
Thank you.
Sure. Any improvement?
Yeah, that sounds better. Thank you.
Okay, I'm sorry. Clenched fist bite. This is a benign, seemingly benign condition, which has actually very significant consequences. Reason it's benign, or seems benign, there's a very minor wound here. Someone strikes someone else, they dismiss the whole injury. When the fist is made, there's a laceration to the extensor mechanism. At the time of examination, that area of laceration is actually now hidden underneath the adjacent skin as the area comes back proximally. The danger is bacteria gets seeded into the joint, which is often violated, but unbeknownst to the emergency staff, then infection develops. Patients can still extend the finger through commissures, which are slips off the extensor tendons that bridge from one finger to the other. If not seen within 24 hours, you have to be considered infected. They're often polymicrobial. Staph is common, but Eichinella most characteristic to incision and drainage in the operating room. Necrotizing fasciitis. This is something that I always worry about, and I worry about it just because the patients can become sick very quickly. They're immune compromised, diabetes, drug use, tobacco, alcohol, malignancies, other medical conditions. And what's a bit scary is generally the wound appears in its early stages very benign. There might be a vivacious appearance to the skin. If there's a wound, there might be slight, like a dishwater appearance, but nothing purulent. Remember, although group A beta hemolytic strep is considered one of the most characteristic, many other bacteria can cause this. The common denominator, they're all toxin producing. Imaging is of little value and quite frankly a waste, although if you have it like this MRI, you see great enhancement along the fascial plane, which is characteristic. A way to establish the diagnosis in the emergency department, infiltrate the area in question with a small amount of local anesthetic, epinephrine, make an incision. If you see erosion of the fascia, you have your answer. And the treatment is pretty extreme. External debridements, you don't necessarily have to extend the area to this degree, but you can do multiple small windows to expose the fascia, irrigate it out, debride it. You're going to need IV antibiotics, ICU stay, pressors, hyperbaric oxygen is talked about. But the critical part of treatment is thorough debridement. Coverage in the once they've resolved acute infections is complex. That closure, maybe something for rubber band coverage. good to have the plastic surgical team on board to help with that. Septic arthritis, we don't see that often, but it is there. Usually it's direct inoculation into the joint. It can also come from systemic bacteremia and an immune compromised patient. What you'll see on exam, certainly swelling, there'll be tenderness along the joint line here, there'll be effusion, surrounding erythema. You have a limited range of motion, pain with passive range of motion. Acute osteomyelitis, acute, you can get away with surgical debridement, IV antibiotic. If it's more chronic, it's going to be extensive debridement, resection of the bone, may require soft tissue reconstruction techniques, longer term antibiotics for minimum of 4 weeks, probably 6 weeks, and may even require digital amputation to eradicate the infection. Atypical infections. This is a little more interesting. These are patients presented here. This is someone with marine exposure, slowly enlarging mass over the dorsum of the hand as well as over the forearm. Multiple treatments, no treatment today, progressive ulcerations, as you see here, lymphangitis, you want to think mycobacterium area. Treated with excision of the synovium to debulk the area with subsequent long-term treatment with medicine called tetracycline, rifampin, clarithromycin. Remember, when you're sending down the specimen, you want to make sure that microbiology understands it has to be plated on the Lowenstein Jensen medium at 30 degrees for 3 weeks. Any less than that, they're going to send a result back saying it's negative. It still might be positive. Still Nelson staining will show these multinucleated giant cells with granuloma formation. Things that look like infection are not infection. When seen, you'll know these. So gout. Gout is a great imitator. Infection looks like gout. Gout looks like infection. If it's an acute attack, the images will be negative. Remember, just because someone has normal uric acid does not mean they don't have gout. Elevated uric acid in the joint is really the sine qua non. If you're able to get fluid from that, it will be negatively birefringent. Remember, if you're sending a specimen down, it actually has to be 100% alcohol. Send a specimen from what you've aspirated and feeling that will dissolve. Treatment will be NSAIDs, steroids, and lavage. So with gout, you'll have these erosions here, cystic formation. Often you'll see between the lunate and the scaphoid separation, which you don't see here. Characteristically, it's periorbital erosions. Similar to gout, but a little different is what we call pseudogout. On X-ray on a patient with pseudogout, you see ulcer-sided calcification. You might not see it in the area actually in pathology. Often occurs with PIP joint with erythema there, similar to gout with NSAIDs, steroids, colchicine, aspirating, lavage. Rheumatoid arthritis or inflammatory arthritis, the joint will be warm, swollen, relapse, nonspecific, may have concurrent infection. If in doubt, you can aspirate. And again, may mimic infection with these erosions here, may mimic gout with these erosions here, a lot of cystic changes throughout this area. Then pyodermic gangrenosum looks like infection, but it's not. It's progressive ulceration, minor trauma, going back to history, some type of GI underlying condition, malignancy, or other comorbidity, medically treated with steroids. So you have to take a leap of faith. So treating these people who you think might have an infection with steroids, that's the way it has to go. And then I'll close with this: things that still mimic infection or not. Malignancies. So these are often slow-growing, multiple treatment failures. Could be tender with erythema, may have a chronic wound. So this is someone with a basal cell carcinoma, not getting better, treated for cellulitis. This here, a patient with ulceration in the skin, looks like it could be infected with squamous cell carcinoma. So in summary, I like to approach this as effective work. Be flexible on your plan. Try and stick to a plan. Treat hand infections aggressively. IV antibiotics are often necessary. Frequent exams, make them NPO. Look for reasons why patients are not getting better. Some occult infections, foreign body. Remember what's cultured in pathology and what pathology, definite culture. Splint early just for comfort and then begin range of motion. Infectious disease service consultation is a great value. Thank you. So with that, I'm going to pass the baton to Dr. Larry Hurst. Dr. Hurst has stood apart from hand surgeons for implementing basic science